and management of vascular injuries in anterior and lateral spine surgeries. Thank you, organizers of MISSABCON 2024, for having me over. I am heading the Department of Vascular and Endovascular Sciences at Manipal Group of Hospitals in Delhi and NCR, and am the Secretary of Vascular Society of India. So as I always say, this is not the first time I am talking to such an eminent audience of spine surgeons. I am the black sheep amongst you all, but a necessary sheep to be present in the herd. Lateral approaches provides effective interbody stabilizations, correction and indirect neural decompression with minimal incisions. It's less invasive compared with conventional ALIFs. However, because this is also a fundamentally retroperitoneal approach, it carries the potential risk to intraperitoneal and retroperitoneal structures because these are the major vessels as seen in the conventional open anterior approach. Vascular injuries have been reported more in the anterior approaches ranging from 1.9 to 26%. These are some of the publications I'm quoting here. It's not that the vessel injuries have not been reported in the lateral approaches. This approach of XLIF was introduced to bypass the need for manipulation of the great vessels from the anterior approach and consequently to decrease the likelihood of their injuries so that they don't come in the way. Experience, well, we have in the past 10 years, we've been a part of approximately 900 plus procedures of anterior spines, disc replacements, lateral spines approaches. 10% actually needed our intervention. Others were managed by the spine surgeons themselves in the form of arterial bleeds, venous bleeds, mobilizations because there was the adhesion, that was a redo surgery. We had one case of DVT post-op. No life-threatening bleed was encountered because we were present. We were given a heads up before and we have all the armamentarium of handling intra bleeds. Concomitant AAAs, the aortic aneurysms have been repaired. We have had atherosclerotic aortas, occluded aortas, wherein they are not pulsating. May-Turner syndrome. We had anticipated that this patient has a stent inside and can cause problems, but rather it made it more easier for us to handle that IVC in which it had a stent. Previous history of DVT, we have to be very careful, and obesity is one place where because of different fusion fascias, the chances of bleeding can increase. So about the tips, tricks and pearls for all the esteemed audience present here, you have to know your anatomy. Any person having a knife in his hand, it is his duty to know the territory that he is going to venture into. The retroperitoneal space has most of the major vascular structures, including the aorta and IVC. You have to know where it divides, the iliolumbar veins, the lumbar veins posteriorly, arteries that can come along, what will you encounter from the right and what will you encounter from the left, what will be lying on the psoas that you're going to on the lateral approaches. These are the basic things that you need to know. The training has to be there a little bit, don't have to be an expert, but the vessel handling, how much can you pull a normal vessel, traction, how much can you apply, holding a vessel, hemostasis, suturing in times of exigency, you need to know how to handle a Castroviejo, clipping, where to apply, and these clips, whether they are steered or not. The nerve and lymphatics, nerves obviously you know, but lymphatics and also nerve injuries causing retrograde ejaculation, they have to be prevented as well. I'm talking about arteries and veins, their branches and variations that can happen. So this is regarding the lateral approaches, the XLIF, the XLIF, the OLIF conventional approaches from you know where to put your incision on and you're going on the psoas. Why I'm showing this here is because if you're going on the psoas and you're not seeing the IVC which is hidden, the retracted blades are the ones that cause the major trauma to the veins, or any of the abnormal veins can be there because you're not having adequate exposure, so this can be injured in the way. You need to know regarding the vena cava that there is if you're going from L1 to L5, it's divided into 6 zones, and Zone A defines the most anterior aspect, Zone P in this figure denotes the most posterior aspect, and the vena cava migrates posteriorly and laterally, as you can see in the arrow, as it travels down from L1 to L5. Proper history and clinical examination is very important. You have to know what antiplatelets or what anticoagulant the patient was on before the procedure and was it stopped adequately or not. Vascular interventions including occlusions, stents, bypass, graft, DVT has to be documented clinical examination, the pulse status, as well as if there is any lipodermatosclerosis, which may denote any venous disease. Venous ulcers may be present, which can be infected. Unequal girth, which may denote any arteriovenous malformations or abnormal connections that may be there because of prior procedures. You have to spend adequate time on imaging, on studying the image in a multidisciplinary team if possible. The fat planes have to be known, relation to the other structures, diameters and calcification should be seen, variation of anatomy, whether you have ileocecal vein or branches of the vessels, kidney, whether it is a pelvic kidney or a horseshoe kidney, duplications if that is there for the IVC, dedicated Dopplers and CT angiogram should be ordered both in the arterial and venous phase to know the status of the vessels coming in between. The planning, every surgery is different, and failing to plan is planning to fail, my dear friends. Multidisciplinary discussions are not an ego issues. It should always be done. The approaches, the intra-op management, how you are going to close, and even post-op, every step has to be discussed in detail that, okay, what medications, what should be improved in our team. DVT prophylaxis should be given to prevent chances of DVT. Mechanical or pharmacological, depending on the Wells criteria, has to be instituted. Intra-op, if you are entrapped in extensive inflammatory reaction, if the vessels are trapped, what to do? Just stay composed, let the brain plan further, don't let it overpower because of adrenaline, don't let the rush happen. Bleeding control is to be achieved with packing, pressure and patience. Compression proximal and distal to the venotomy side, using hemostatic agents such as sponge sticks, depending on what kind of bleeding is there. Artery hemostat should not be applied in haste, they cause more bleeding. Suction is usually avoided so as to decrease the extension of the venotomy. Vascular clamps are rarely applied. You put pressure, in between you put suction if you are planning to close that venotomy, otherwise that will lead to more bleeding. Patient positioning is preferred in Trendelenburg to decrease the venous pressures in the lower extremities, and definitive repair is attempted after the patient has been stabilized, the anesthetist has given enough fluid, including volume recovery. Till that time it is kept pressed and the resuscitation is happening along with. The venous bleed, as I have told, that is because of split retractor blades that injure the vein. The venography should be performed with 4050 protein stitches. Topical agents can be used to reinforce incomplete repairs. Those that enhance clot formation and hemostatic agents, including porcine gelatin, oxidized cellulose. If you suspect a bleeding, if the patient is sinking, you have to make adequate exposure, you have to change positions, you have to pack it, and then you have to do definitive repairs. Don't let the procedure go on with ongoing bleeding. That can lead to DIC later on. Venous thrombosis can also complicate suture repair of the left common iliac vein, where the diagnosis can be made by post-op MR venograms. Dense adhesions or suspicion of occult thrombosis, you can place IVC filters or stent graft placement in the left common iliac vein can be done preoperatively. If there is an arterial injury, most of these cases happen due to fixed retraction in anterior approaches on the iliac vessels, including mechanically fixed retractors and Steinman pins. The iliac vessels, whether you're retracting by hand or instrument, they have to be released intermittently at 20 minutes intervals to decrease any chances of thrombosis, because you're not giving heparin intra procedure, so these vessels can clot. Identify the predisposing risk factors, including spondylolisthesis, osteophytes, previous infections, whether this is a revision surgery or any prior anterior surgeries have been done. A team approach is always medico-legally beneficial. There is better intra-op management, there is peace of mind, the responsibility is shared. Concomitant pathologies like aneurysms can be treated with anterior approaches, and there are lesser vascular complications. To conclude, ladies and gentlemen, minimally invasive and less invasive lateral surgeries may be a trade-off with limited visualization of the retroperitoneal space and minimized working space. We would recommend that you have a combined approach between spine and vascular surgeons. This should be the standard of care for all patients undergoing anterior and lumbar spine procedures. This is likely to increase the safety of the technique and the confidence of the emerging spine surgeons will improve. Thank you for your time and patience. We are open to any questions or comments. Thank you.